So I will start off. And again, thank you, everybody. Good morning. Thank you for joining us today for the Delivering Mental Health and Addiction Services during the COVID-19 pandemic webinar. My name is Nina Salazar, and I am the project coordinator for the Canadian Centre on Substance Use and Addiction. Before we get started, I would like to acknowledge that the land on which we gather is the unceded and unsurrendered territory of the Algonquin people. Today, we're going to hear from three speakers who I will introduce shortly. I'm sure you guys have been watching them this morning as well. So as we all know, the COVID-19 pandemic has caused many disruptions in the lives of Canadians, including disruptions in access to and delivery of mental health and addiction services. This webinar will explore how the measures to reduce the spread of COVID-19 have created challenges for those seeking care. It will explore the inequity that exists in access to services and the opportunity for innovative solutions to support Canadians during a time when we're seeing a growing number reporting worsening mental health and increased substance use. Now, before I introduce our speakers, I do want to note a few housekeeping items. Please note that all lines will be muted during this call to ensure sound quality. Please also note that videos have been turned off, and we ask that you keep them turned off during the webinar. We will also be recording this webinar and will be posted at ccsa.ca/webinars. If you do experience any technical difficulties, please call TELUS Business Connected Meetings technical support at 1-844-626-6638. You'll also be able to find this in the chat line. Now for our introductions, our first speaker is Dr. Peter Cornish, an honorary research professor at Memorial University and Director of Counseling and Psychological Services at the University of California, Berkeley. Dr. Cornish's clinical and research interests include online mental health, Stepscare treatments, mental health services, innovations, and interprofessional team functioning. Over the past 5 years, he has provided consultations and on-site training on his Stepscare 2.0 model to over 150 organizations across North America. His nonprofit company, Stepscare Solutions, is the lead partner in Wellness Together Canada, a federal COVID-19 $70 million mental health program for all Canadians. Now, following Dr. Cornish will be Dr. Kim Karas. Dr. Karas is a Vice President of Innovation and Transformation at the Royal Ottawa Mental Health Centre. She is an Associate Professor in the Department of Psychiatry at the University of Ottawa, an Adjunct Research Professor at Carleton University, Clinical Investigator with the Institute of Mental Health Research, and a Clinical Health Psychologist. Working at provincial and national and international levels, work focuses on improving treatment access and outcomes for people living with substance use and mental health comorbidities, with a focus on developing collaborative care models. Our last speaker for today will be Dr. Peter Selby, a senior medical consultant and clinician scientist at the Addictions Division, the Center for Addiction and Mental Health. He is also a professor with the Departments of Family and Community Medicine and Psychiatry and the Dalla Lana School of Public Health at the University of Toronto. Dr. Selby's research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His most recent program of research uses a learning health systems approach to investigate how technology-enabled collaborative care can enhance the delivery of evidence-based interventions to the patient while providing a more satisfying experience of care for both patient and provider. Welcome, doctors, and thank you again for joining us together today. Now, to get started, I'll now turn it over to Dr. Peter Cornish.
Hello, welcome everybody. It's my pleasure to kick off the webinar. We're going to begin the webinar by taking a little tour through Wellness Together Canada. We'll put it in a bit of context in the context of Stepscare. And let me just see if I can share my screen to share here. Now, I just want to confirm if somebody's not on mute, if you can see the title slide here.
Looks great, Peter.
Good. Okay. Thank you very much. So in April of this year, we launched this portal after a whole 10 days that we took to develop it. So very, very quick implementation. and we've been working since then to make changes to improve the user experience. So currently the user experience is pretty much based on what was launched about 6-7 months ago, and we're going to see a lot of improvements in terms of the user journey. So keep that in mind as I take you through the portal. But beginning a little bit with some background, it's the Wellness Together Canada portal is based on a program that we call Stepscare 2.0. And it's obviously a population health level intervention, which is not meant to replace the kind of care that you get in provincial and territorial systems through clinical care, outpatient care, inpatient care. It's really meant to fill a gap. There's an access gap. Many people find it hard to get care immediately unless they are in crisis. And so Wellness Together Canada offers support, including counseling, along this stepped care continuum, but doesn't include or replace tertiary care, primary care, or acute care in hospital settings. But the idea is that people can get immediate care through a variety of means, whether it's text, web-based, or actually talking to a live human being. And this is quite different from the way that care is organized traditionally in my profession in psychology and in other professions, where a lot of preliminary work is done to assess and route people to what is considered to be the right level of care. Instead, what we do with Wellness Together Canada is we have care immediately available that people can try. They can use a trial and error approach to try something, and if that doesn't work, they can try something else. And this is informed by continuous monitoring data. And stepped care is a very different. Step Care 2.0 is very different from our current system. And so we've worked hard in collaboration with the Mental Health Commission of Canada and CAMH to produce a implementation guidebook. And there are a lot of principles that folks on this call might be familiar with that are embedded in the model, including recovery-oriented approaches, which assume that people have a lot of capacities and that we don't have to simply focus on removing deficits or treating symptoms, but building on those capacities. In so far as recovery does not necessarily mean that you have a cure of your addiction or mental illness, but that you have lots of supports that can help you to live a meaningful life. There are 9 different core components, one of which is Codesign, and that's core component 1. Key stakeholders are always involved in adjusting and developing and correcting the system. Stepped care is meant to be self-corrective, both in terms of the experience of care. A user coming on Wellness Together Canada can do the trial and error thing, but it's also the whole system is meant to be self-corrective. And part of that corrective self-correction happens with people with lived experience joining us. And we actually, some of the early corrections that we undertook were from folks with lived experience of addiction who said that one thing they said is that the sign-on was too rigid and that people had to sign up and do an assessment before they could get care. So now we rapidly changed that and so that people don't have to sign up, they don't have to do assessments, they can go in and get care without assessments. So the other components include things like continuous progress monitoring, single session thinking and approaches where care with a counselor is right up front, structured psychotherapy care, so that in that single session, every person walks away feeling like they got something useful, as opposed to sometimes in our tertiary care systems where it really makes sense to do a deep dive assessment. You might end up walking away from a first encounter without any care at all. The Wellness Together Canada program is a partnership of three organizations: Stepscare Solutions, Kids Help Phone, Homewood Health. Stepscare Solutions doesn't provide any direct care. We're more the architects of the system. We help manage it and build it out and advise on changing it in accordance with the stepped care model. Whereas Kids Help Phone, they provide the direct counseling care, and Homewood Health, Kids Help Phone for youth, and Homewood Health for adults, as well as a lot of other resources that you can find in their systems on their webpage. And Wellness Together Canada routes to them either directly before sign-on, so you don't have to sign up to get counseling care, or once people have signed up and are monitoring their care and getting access to all the tools, they can still go to Homewood Health or Kids Help Phone for care at any time. And it's immediate care, immediate counseling. This slide shows, and I know it's hard to read, but it shows the 9 steps of Stepcare 2.0 with the logos of the different programs that you can find within the portal. And recently introduced was the Breaking Free Online program, addiction program, and there will also be a peer support addiction program coming online in the weeks to come. So we recognize that there are still gaps in some of the programming, and we'll be building out and filling those gaps in the next few months. So in June, we had a marketing campaign, Take That Step, which was endorsed by the Minister of Health, and she actually received a pair of shoes like this, as did a number of other people. And I'm still waiting for my pair. I was supposed to get a pair of shoes like this, so I'm not sure what happened. They probably got lost in the mail, and it might be one of those stories where my grandchildren years down, 50 years from now, maybe that parcel will be found and they'll get the benefit of wearing these shoes. This is what the landing page of Wellness Together Canada looks like. And if you scroll down, you can see some of the functions. If you do sign up, you can do continuous monitoring to look at your health metrics. You can get access to 11 independent programs, including self-guided apps and online communities of support or one-to-one counseling. And if you don't want to sign up, you can go straight either by clicking on the adult resources or user resources to Homewood Health and Kids Help Phone for immediate support. I'm going to come back to the portal in a moment, but I just want to show you a little bit of data here. This is a bit of a busy slide, but to date, just this morning, we saw that there had been over 669,000 unique visitors to the site. And of those, we have, I think this is probably at least a month old, 49,461 registered users. I think we're closer to 60,000 right now. And the little pie chart down below might be hard to read, but what we find is that of the registered users, what is most popular are the self-guided apps, followed by a community of support, and then or coaching, and counseling somewhere in the middle. And we were kind of surprised by that. We thought that most people would want to have free counseling right away. And while that is increasing as more people become familiar with the portal, it looks like on a population level, people are more interested in self-guided. Now that would be different for people who we imagine would have diagnoses of depression or anxiety or substance use. And what we find when we've done a little bit of polling in that area is counseling does come out number one in terms of preference. A bit of data that we've collected here through some national polls shows that when you ask people questions that relate to the 9 steps, we find that similar to what we've seen on usage on the poll, when you survey a random sample of Canadians, most people, up to 46%, want to do activities that they can do on their own. This is a step 1 kind of category in the Stepscare model, mental health literacy. Let me just, or actually the second item, information about specific concerns, is mental health literacy, whereas activities that you can do on your own, we classify in the Stepscare 2.0 model as self-guided programs. And then you see a close third, people are still interested in one-to-one counseling. Our guess is that many of those people would be satisfied with a single session, one at a time. And single session is like what you get when you go to your GP. You don't expect to have a course of care through your GP. You go in once, you get something useful, and if you need to, you can come back again. And this isn't meant to replace the kind of psychotherapy or psychiatric care or specialist care, treatment center care that many people with diagnoses need, but we think that in fact, some of the early research on single session suggests that up to 80% of people who are seeking help and want to speak to a counselor, a single session approach can be the most beneficial. And it's a very structured type of psychotherapy if training, if good training is provided. And we've made sure that the counselors at Kids Help Phone and Homewood Health have been trained by one of the, or two of the world's leading experts, and they continue to get training in that care. In the next version of Wellness Together Canada, we will be linking, providing directories to link people to other types of care that are not part of Wellness Together Canada, including into the provincial and territorial systems, as well as organizational resources that at this point we weren't able, there's so many that want to be on the portal, we weren't able to build that up. And this is consistent with what we're finding Canadians want. When we asked them what sort of features they would like, the one that came out top was a listing of resources available in your area. And so this was something that we heard from stakeholders before and is now confirmed by a poll that people would like to have more information on the portal. When we asked people who might encourage them, or how would you be more or less likely to use Wellness Together Canada if it was recommended by, and this list here you see on the left, what we found was that people would be more likely to use it if their physician recommended it. And so we need to get this portal and the information about it into the hands of physicians and others. In our poll that we did of Canadians, only 10% were familiar with it, and that includes people that weren't, incredibly familiar or hadn't even been to the site. And so we need to work at getting this information out, because the 669,000 people who have visited, I think we would see a lot more if people simply knew about it. We're also working on continuing to change how people will experience the portal, because we asked people what might be the barriers to using a system like this, and the privacy stood out as one of the most important or the biggest barriers. And so we dug in a little bit deeper after the first poll, where we found out privacy was an issue, and we discovered that these are the kinds of things that people would like to see in the portal, the ability to delete your information, and more information about where that data is stored. And so we're working on developing that now. And this is just an example of a promotional tool that is available to get it. We're working on getting these kinds of things out to physicians and other agencies. And so that's the presentation. And if there, I'll turn now to Nina to ask: is there any time to go through quickly the portal, or should we move on?
No, we have some time for some questions.
Okay.
Perfect. Okay, so first things first, are the resources for free? That was one of the first questions we got.
Absolutely, they are free. And in fact, that was one of the barriers that we saw in our first poll, was that people thought they wouldn't go there because they were afraid it would cost them money. and it's all completely free.
Fantastic. And I will be getting some of the resources, the links, and then we will provide them to our participants after the webinar. Another question that we have here is, did you have any insights into the strategy to keep the directories updated, details of providers and agencies?
That's just in development right now, and so the key would be working groups and partnerships particularly with provinces and territories. In fact, there's the province of Newfoundland and Labrador is already working on a list or a program of directories nationally, and so one of the things that we're thinking we'll do is partner with them and integrate their work on a national page with directories.
Perfect. Thank you so much, Peter. Another question that we have here is someone had mentioned that this model is very similar to the Foundry model in BC. Was there information shared about this model when developing this Canadian program?
Yeah, we work pretty closely with Foundry. In fact, our group, Stepscare Solutions, is currently doing some program evaluation. We conducted focus groups and we're analyzing that data. And so we were really working hand in hand with Foundry. There are different ways of doing stepped care, and we're always exchanging the latest approach. One of the things that some implementers of stepped care do is they use they base step decisions on symptom severity. We're working now with Foundry to explore ways of making it more flexible. Just like Wellness Together Canada, people coming to the site get to choose what they want to use, as opposed to a professional doing an assessment and deciding based on that assessment, this is where you should go. We actually think that preferences can be much more, can be part of the decision-making process in tertiary care and primary care settings more than it is right now. And those are the kinds of conversations we're having with Foundry and other groups like the WIHU groups in Ontario, the youth wellness hubs across Ontario.
That's fantastic, Peter. The questions are just coming in right now. All right, so another question that we have is there accessibility of information for deaf and hard of hearing, i.e. closed captioning of videos?
That is not there right now, but it is certainly something that we're considering. Our funding has been in 4-month sections, and so it's been really hard to know up until to date whether this is something that's going to live on. And so the development to make it more accessible is something that we've had to hold back on. But there are some signals from Health Canada that they want to make this for more permanent, and they're considering whether to fund it for 1 or 2 years, at which point we can do a lot more investment into the user journey experience, which of course, accessibility, there's so much more that we could do on that. Right now, only the front page that you're seeing on the screen here has some design elements into it. The rest of it was just something that was spun up in that 10 days period. But now that we get signals that there's going to be a longer term commitment, we're putting some money into the design and the user experience.
That's great news. Another question that we have here, is there a pamphlet that can be handed out to clients when telling them about it? And another question very similar to it was, where can we find promotional posters, material to distribute?
Yes, so at Stepcare Solutions, we do have a whole bunch of materials that are now available. So anyone could ask, could email us at Stepcare Solutions, me, Peter, at stepcaresolutions.com, or contact any of the organizers of this webinar, and we can make sure that we get promotional materials out to you.
Perfect. Thank you again, Peter. I will conclude the Q&A at that point. And again, thank you so much, Peter. This has been fantastic. And to everybody, I will ensure to have these resources and links available after the webinar. I will now pass it on to Dr. Kim Karas for her presentation.
can you hear and see me okay?
I can.
Okay, great. Let me just try this with the slides. Just having a hard time getting into the slideshow. 1 sec. Is that okay?
Looks fantastic.
Okay, great. Thanks, Peter. That was really a great presentation on an innovative method to improve access and connection to care for people living with mental health and substance use problems. I'm going to talk a little bit today about some work that we're doing also on improving access to care during COVID, specifically for patients with opioid use disorder and related conditions. So this work was sponsored actually by CCSA, as well as with in-kind support, both from CCSA, the Royal, and where I'm at, as well as Women's College Hospital. And none of us have any conflicts of interest to declare. So just some background. Obviously, we know this, especially many of us are providers in the room or clients or families or people ourselves who work with other people who have substance use or mental health problems. People who use opioids are a priority population affected by COVID. Many populations are affected, but those who use opioids are disproportionately affected. There was already an opioid crisis, as I'm sure you all were very well aware, in Canada, and COVID has really exacerbated this crisis. We have seen overdose deaths increase across Canada, and we've seen that in Ontario, where I live and work as well. COVID's really interrupted access to treatment. For the last 15 or 20 years, I've worked with people with opioid use problems, and I've unfortunately witnessed that devastating impact that barriers to accessing quality care has had on my patients and on their families. People literally are often dying while they wait for care. And now, more than ever, because of COVID, we need to ensure people have access to the care that they not only need, but that they deserve. Opioid agonist therapy is considered the gold standard of care for opioid use disorder treatment if you look at clinical guidelines and the research around that. However, prior to COVID, in Ontario anyway, OAT rules are pretty highly regulated and rigid. That may mean clients have to present frequently to pharmacy or their prescriber, sometimes even daily for their medication. Follows a rigid dosage schedule and monitoring schedule. That means frequent office visits, urine drug screens, as well as supervised dosages. So how can we make sure during COVID that people who are in most need of OAT or opioid agonist therapy can actually get access to the care they need and also maintain the care that they may have already been involved in? So a group of Ontario clinicians modified the treatment guidelines for OAT early in the pandemic that would support public health recommendations so that it would allow safe access to care and continuity of care during the pandemic, but also support those physical distancing requirements to keep people safe. So the purpose of what we're going to talk about today is work that we've done to assess how care delivery has been affected by the COVID OAT guidelines, both from the client and prescriber perspectives. So what we did is we did an online survey that we co-designed with people with lived and living expertise, as well as with prescribers. And we wanted to understand both client and prescribers' experiences with the new COVID OAT guidelines in Ontario, as well as how their access was affected and how their delivery of care was affected. So we surveyed clients and prescribers. 354 clients and 76 prescribers completed the survey. As you can see here on the left-hand side, for clients, we wanted to look at their experiences with changes in the frequency of office visits and urine drug screens related to OAT, their number of carries, as well as their perceptions of virtual care. And for prescribers, we wanted to know, were they aware of these guidelines? What were their experiences implementing them, and what were their experiences with care delivery under the OAT, under these new guidelines? So here are some of the results that you can see here. I don't know if you can see when I circle things, so I'm going to do it anyway. You can see the majority of people were men between 30 and 44. However, 47% were female as well. The majority were white. although 20% were from various other ethnicity and racial backgrounds. You can see it was pretty well distributed over the types of OAT care, although there were a higher percentage of patients receiving Cadian or Strom, as well as Sublocade than we would have expected, given what we know for the general population of people who get OAT. You can see here that in terms of past 30-day use, 40% of people on OAT reported that they were also using opioids, alcohol, as well as about 20 to 30% using cannabis and cocaine. Most people, so 50% of people, so not quite most, but about half of people on OAT reported that their opioid use increased during the pandemic, and about 53% reported using opioids by injection. If we look at who our prescribers are, you can see here the majority of prescribers were female. About 40% were working in an OAT clinic. If you look over here, you can see too that about 57% were in an urban setting, 26% were in a rural, and 10% remote, and 8% on reserve. So you can see actually we had a pretty good group of prescribers from across different types of settings. So what did prescribers' views were in terms of their awareness? 93% of prescribers who completed this survey had read the interim guidelines. Of those prescribers who read the guidelines, almost 100%, so 99%, reported changing their practice as a result of these guidelines, and most supported the change. That is, about 80% felt that those guidelines were reasonable and balanced, and about 70% said these guidelines gave them the right amount of structure for allowing them to use their clinical judgment for decision making. So it was a good balance for them. Okay, so what about clients and prescribers self-report related to changes in frequency of office visits? Remember, we were hoping that these guidelines would actually reduce some of those office visits so that it reduced some of those barriers to accessing care and supported the physical distancing requirements. You can see here that most clients actually reported no change in the frequency of their office visits, whereas prescribers reported a decrease in frequency. Remember though, when I showed you the initial methodology, however, these clients and prescribers are not matched. That means not all of these clients have these prescribers, and all of these prescribers, these are their patients. So these are independent samples in that way. We saw the same pattern of frequency for urine drug screens, with most clients actually not reporting a change in the frequency, but prescribers reporting a decrease. What about increases in carries? The majority, so close to 60% of clients, reported receiving additional carries or take-home doses of their OAT during COVID. So let's look at what that looks like a bit more specifically. So on your axis here, your x-axis, this is the maximum number of carries that clients reported before COVID. So this is client reported increase in carries during COVID. Here are their carries before COVID, grouped into 0 to 1, 2 to 5, and 6+. And the blue is methadone, the orange is buprenorphine, and the purple is Cadian. And here's the percentage of people who receive, patients who self-reported receiving additional carries. You can see overall, we see that clients, regardless of OAT type and pre-COVID carry level, were reported being prescribed additional carries. In that, those clients who had 2 to 5 carries, regardless of OAT type, prior to COVID, were more likely to be prescribed additional carries during COVID. What about what prescribers saw? So most prescribers reported prescribing carries or take-home doses to patients who were previously not prescribed any carries. So that means prior to COVID, if patients weren't prescribed carries, prescribers are saying, you know what, these guidelines, by following them, we prescribed additional carries to patients. They also reported the same for patients who are already prescribed carries pre-COVID. Few prescribers reported decreasing that frequency. If you look at this graph here, or sorry, this table here, you can see the maximum number of consecutive carries pre-COVID and during COVID, and overall there was an increase. You may not see as big on the median here, but you could see how much more the range has increased too. So what about responses to changes in care delivery? So overall, most clients and prescribers responded quite positively to changes in their care. What I actually found most interesting is that 60% of clients reported that they felt with these changes in OAT guidelines that they could actually be more open with their prescriber. And nearly 3/4 felt that their changes helped protect them from COVID. When we look at what prescribers felt, 70% of prescribers reported that their ability to prescribe more take-home doses or more carries to their patients improve their relationship with their patients. So we're seeing these guidelines actually result in a self-reported, from both client and prescriber perspective, improvement in relationship. Most clients and prescribers reported being satisfied with virtual care, noting there was room to improve. About 2/3 of clients felt that virtual care improved their access to OAT care and access to their prescriber. And about the same of prescribers felt satisfied, but there were some concerns about from prescribers about whether or not that virtual care, whether or not they could assess clients as well as they could in person. Clients reported many benefits to getting additional carries, including saving time and saving money and increasing access, but they also noted some challenges. What's most interesting is we actually compared those people who received additional carries, those who didn't, and looked at self-reported adverse health outcomes. And we found that according to patients, additional carries or take-home doses were not associated with with increase of self-reported health outcomes in regards to no increase in overdoses related to opioids, no increases in emergency department visits, or no increases in hospitalizations. So what does this all mean? Overall, most clients and prescribers responded very positively to changes in care delivery. So I think it also shows the importance of ensuring that Canadians have access to this life-saving care for their opioid use disorder. So this means not only reducing the barriers to care, but also increasing prescribers' competency with delivering the care, scaling up those programs that offer rapid access to treatment, and also ensuring access to virtual care for all Canadians. We still live where that many people in areas of the country that they live in, frankly, in areas of the city we live in, don't actually have good access to virtual services. So we need to ensure that no matter where people live in this country, they get access to the care they need and deserve. And a few other things, sorry, I'm just looking at my time, so jockeying between screens here. There were some limitations that impact the generalizability of these findings. This was an online survey, so this means that it may not have reached some of the priority populations within for those clients who are on OAT. I am involved in another research project where we're looking at those populations as well as doing some more qualitative interviews with patients. We need to really, as I mentioned, scale up those programs that facilitate timely access to care. And also, we've really changed our policies and regulations and supports to reduce barriers to increase access to OA care pre-pandemic. How do we continue to do this post-pandemic? How do we take the learnings that we have now and the outcomes that we have here to really support increased access and reducing barriers to care post-pandemic? As I mentioned too, really focusing on how do we help increase the capacity of providers through national guidance and training so that they have the tools and the resources that they need, and the patients have the tools and the resources that they need to access really important care and services. I want to thank many people. I'm presenting this work, but it's on behalf of many of my colleagues. I'd like to thank our lived and living experience family and friends team members from CCSA. I'd like to thank those who are the contributors of the COVID OAT guidelines, the participants, as well as our research team member for making this possible. So I will turn it back over. I think what I just saw in the chat is that we will have the questions and answers after. So thank you, Nina, and for the other CCA folks for inviting me to be part of this, to discuss this today, and I look forward to questions afterwards. I'll turn it over to Peter.
Thank you, Kim. Peter, you're next.
Okay, hopefully this will work. Can you see my slides?
Looks good. Oh, you're muted, Peter.
unmute myself. Okay, good. There we go.
We can hear you.
Hi, thanks. It's very hard to follow such great speakers, but I'm going to try my best, and I want to make sure we have enough time for questions. So I'll speak to this based on my experience, and we will see how we go from there. So, okay. All right, that's me. Disclosures, nothing to disclose for this. Two things. We'll take a look at the CAMH surveys that started and up to July, and then look at what some of the adaptations we've done both for clinical and population level care at CAMH. For those of you who are joining and don't know CAMH, CAMH is the Center for Addiction and Mental Health. It's a 22-year-old organization. It's the largest mental health and addiction facility in the country. It's fully affiliated with the University of Toronto, and has a 500-bed hospital, takes care of patients both inpatient, outpatient, publicly funded, has a large research program right from molecular to all the way to population level, has a large education department, as well as has a large policy and implementation program as a provincial organization. So that's where I work, just to situate the work. And we got really busy as soon as the pandemic hit. By on the 18th of March, when a global pandemic was declared, within that week, we had launched our website and our web resource. And as well as had made several modifications to the care of patients who were admitted to our hospital. So I'll take a look at the survey that came out of our colleagues' work at CAMH from a policy and a population health group in combination with our IT group and Delvinia. So what this happened was serial surveys with Canadians represent a sample of a panel of Canadians from May all the way to July, and it was done every 3 weeks. And I'm going to give you high-level information. You can actually go to the website, and which I'll show you in a bit, download these information, take a look at the data, and here's what we know. We know that roughly about 20% of Canadians are experiencing moderate to severe anxiety. This is based on the GAD. But binge drinking has also gone up to about 27%, so much higher. And feeling lonely is at about 23%, and depression is about 18%. And it seems like fairly stable over time. The 1/4 of people report engaging in heavy episodic binge drinking, so that is beginning to be a concern, that the amount of people binging seems to have gone up. And again, this loneliness and anxiety are coming in, and you can see that switching to working from home are more likely to have moderate to severe anxiety compared to other groups. And it could be reversed, right? So the more anxious you are, the more likely you may be to stay home, versus those who are less anxious may be more likely to go out. So we can't tell you the direction of that, but it is an association. There are some age differences. You can see that overall anxiety was high at the beginning, as you would expect, and then started to creep back up a little bit towards July, and kept going down, but crept back to July. And we're going to see what happens in the future, depending on if we can get funding for these surveys to continue. You can see the sex differences between anxiety. Women were much more likely to report being anxious at the beginning, but it seems to have sort of reached some sort of convergence. But you can see that having children in the household really seemed to be putting that up. And so I think if you live with kids under 18, that is, as expected, sending the levels of anxiety up. And now we'll have to see after one school semester what has happened. When you take a look at stress and substance use, binge drinking among women nearly matches that of men across all ranges. And this happened in a span of 9 weeks. So initially, as we know, there's a difference between men and women's binge drinking, but you really got pretty much coming close. And it's beginning to diverge a little bit again. And we're not sure what this is. But again, one in 3 Canadians who binge have children at home, and about 60% of these people are worried about their finances. So I think we're going to see some trailing effects of the pandemic with respect to having sensitized the population to heavy binge drinking, but to be seen. So that's just the rough level of the survey. And the second thing I want to just let you know is what we did at CAMH during COVID. And this website is up for free. It's what we started out in March, and it's the tagline is "A Part Not Alone." And again, if you look at it, has several aspects to it. There's a whole section on resources for healthcare workers, including sign up for teleeducation through ECHO, which is for healthcare workers to manage and learn and get support and learn how to cope with COVID, and that is available. There's a whole bunch of additional resources and FAQs. We made it very simple for people to access, and we talked about there are some policy advice papers as well. We also, at the time, based on our experience with SARS-1, started an online discussion board, which is moderated, and it's still active, but the use is not as much as we thought, and I think that's because people are getting support online through Twitter and other formats. But it is there, and it is moderated, so we're going to keep seeing how it works. The other thing is that there's lots of other aspects that people have told us that they wanted on. So we've had stories from people with lived experience of mental illness and how they've coped with COVID. We've had the loss and grief and how to cope with that and how to manage uncertainty. That's new. Obviously, it's managing stress and anxiety. What we noticed with every pandemic, stigma and prejudice, and our patients are no different. So figuring out how to manage that, and obviously quarantine and isolation for those who've got feeling how to handle their mental health during those periods. And of course, there's a whole bunch of advice for free. So that's there. And of course, what we did is transform this passive information into an app. It's available on the App Store and Google Play. So for people who don't have stable internet connections can access it there. We also had to pivot from a clinical perspective. The emergency room has continued to stay open and has become a conduit into the hospital. We've had cases of COVID, obviously, in the first wave, and obviously COVID with staff as well as with clients. And we take that very seriously. There's a task force, like any public hospital act, with the IPAC, making sure that people are safe. I'll speak a little bit about addictions. Obviously, our opioid use disorder clinic continued to stay open, and Dr. Corres talked about it. We were involved in the modification of the guidelines, but that has stayed open. Our medical withdrawal service has stayed open as well, but all the admissions are funneled through the Emerge. But another addiction which did not suffer, and we continue to do that, is continue to offer our smoking cessation services, because, as you know, tobacco is a big risk factor for getting quite significant COVID, and quitting smoking is highly recommended during COVID. And so we continue to offer the appointments we pivoted from from in-person to online using something called WebEx, and that was authorized by the hospital, and we continue to do that. Both the physicians, like myself, saw patients that way, as well as the counselors, and we've also started online support groups and skill session development. We also pivoted our large program in Ontario to online, and any Ontarian who smokes can sign up for free 4 weeks of NRT through the online portal, self-help program. There's one for young adults as well, called Stop Yaya. That also is available for youth and young adults. So we've pivoted to make sure that there's services available in Ontario for this addiction that kills more Ontarians than what COVID will, and more than all other substances combined. The other thing we did is, just before COVID, we created an online platform to help primary care to manage opioids. And roughly this pathway is scalable anywhere. And we were about to launch when COVID hit. We are now connected with our primary care partners and reassessed their willingness, and we've got a lot of willingness. But basically, this electronic pathway helps non-specialized settings figure out how to identify patients who are using opioids, how to enroll them, how the patient does a self-assessment on this online platform, or if they have digital poverty or digital literacy issues, they can get the practitioner to help them. And then it guides the practitioner with automated guideline-based recommendations to help co-create a plan with the patient to manage their opioids, whether it's opioids for pain or opioids for substance use or for opioid use disorder or both. And if the practitioner requires additional guidance, they can get an e-consult, they can sign up for courses, they can join the listserv, or they can get a virtual care of experts who we are putting together to guide them on how to manage that patient in the comfort of their homes and not having to travel all the way to Toronto. And then those data are then fed back to the practitioner, and then follow-up is done automated through this system at the desired time, with the goal that the patients are protected from the harmful effects of opioids, whether prescribed or otherwise. So that's that, and and Dr. Corey spoke to you about the guidelines, so I won't go over that. And I just want to thank you, and hopefully we have time for questions.
Thank you so much, Peter. Hi, Peter. Thank you so much for that. Let me just quickly share my screen again. Perfect. I just moved this. Fantastic. Okay. Well, thank you again. That was great. Again, I promise to have all those resources provided to everybody as well after the webinar. So just a quick couple of questions here. Let me just take a look at the list here. My apologies. Okay, so what is your sense of client relationships with harm reduction programs, in your opinion, safe supply related to opiates? I believe that was for Dr. Karas.
Okay, sorry, I wasn't too sure. So in our study, we focused on access to opioid agonist treatment. However, some of the additional work that we're continuing on is going to include, obviously, people from clients or prescribers from the safe supply sector as well, given that many of them are also on OAT. And it could have been that some of these clients who completed our survey were also as part of one of the safer supply programs as well. But I think the question was about the relationship to harm reduction, and obviously, I think first I was answering just in regards to who we studied, but obviously access to harm reduction needs to be incorporated across all levels of the continuums of services that we provide, whether people are, no matter where they're receiving services, because that's a really important component of treatment, and guidelines and other sort of indications for how we offer OAT would say the same. I don't know, Dr. Selby, if you want to add anything.
I mean, I think the issue around, safe supply is that the issues that we've seen in Ontario is that we've seen an uptick of prescription opioids going up since March. Now, whether that's part of safe supply, we have no idea, or something else. But or just people are giving longer prescriptions to their patients who have pain disorders. The issue is, first of all, we should call it safer supply as opposed to safe, because especially, and it means different things. It's a highly unregulated, not well defined what we mean by this, and the evidence is poor. What we do know is we have evidence of life-saving treatments, both methadone and buprenorphine. Methadone more than buprenorphine, especially in the face of fentanyl. And it is actually extremely horrific that policy level interventions and other interventions have actually decreased the number of people prescribing methadone in the province. That's not a good thing in the face of an epidemic. And although, yes, buprenorphine has gone up, it still is not enough. And so clearly there hasn't been a compensation in increasing safe supply of methadone and buprenorphine more widely, which we know will save lives. So it's very hard when right now, from a policy level, to make sure that those molecules are not more widely available in the population, because we know that saves lives.
Thank you, Peter. Thank you, Kim. Next question that we have is, in terms of providing virtual care to opioid users, part of the homeless population during COVID-19, how are they accessing OAT guidelines virtual care, and would these reports be completed with their prescribers?
I can speak to that a bit.
Yes, go ahead.
Yeah, because I don't know if the guidelines will address all of that, but I could just speak from experience of doing this work, and then Dr. Selby, you can go ahead quickly. I'm sure it's probably the same. The guidelines weren't to take away and only do virtual care. They still allowed for in-person care as well. And I think Dr. Selby mentioned it from CAMH, we at the Royal continue to, and many of our community partners continue to provide in-person access to services, and us including through our rapid access addiction medicine clinic. So there have been interesting models as well that have looked to how we can work with some of our partners from the housing and homelessness sector in terms of how we can also increase their access to virtual care by providing equipment to some of those other settings and through partnerships. I'm going real quick because I'm looking at time. Go ahead, Dr. Selby.
No, go ahead, Dr. Perez. You covered it. I mean, look, the two populations who suffer the most during pandemics are people with severe mental illness and people with significant addiction. So, digital means can help certain numbers, but more importantly, you need to help patients directly. So the problem is many addiction sectors especially did not have adequate PPE or training or possibilities. And so some of them actually went offline. Now, most opioid use disorder treatment programs haven't, but the non-opioid use disorder, community addiction treatment program, many of them weren't able to stay open or to provide services. So that is a concern, of course, and PPE distribution is a problem. So these patients are a special population who do experience more of the pandemic than others.
Thank you, Peter. Thank you, Kim. Now, we are out of time here, but we have a couple more questions. Would you like me to just send them to you, or do you have a couple of minutes to answer them?
I have a couple of minutes. I've got another meeting to go to, but I don't know about you.
Yeah, I have a meeting starting right now, but I can do a couple minutes.
Yeah.
It's probably easier.
Okay, fantastic. So one of the questions that we have, again, talking about virtual care, what are the specific barriers to virtual care in rural, remote, and reserve settings, and ideas to mitigate?
So I can go with that if you want. So one is, we have this issue of digital poverty, which means access to technologies and the reliability of technology. So that's certainly an issue up in rural communities. And the second piece is that you have digital literacy issues. So ways and we are doing this in our small study here in my lab, is figure out asynchronous means of communication, so that, and don't forget the telephone. It's a lifeline. So the telephone, in fact, is the most popular and most used form of virtual care, so don't get rid of it. So that's one. And the second is that if the healthcare provider has access, then we can create digital access through the healthcare providers, rather than the individual who may not have that literacy. And that's what you saw in that river of care diagram that I showed you. You need systems that have that flexibility. So that's how I would say is possible. But I'll leave it to Dr. Perez to close us out.
Yeah, and in addition to that, all great points, Dr. Selby, and I'm sure this was also on your list because I know the work that you're doing. It's also the environment wherein people live. So if you are living in an environment where there's multiple people living in your housing, having even access to private space within your residence or where you're living to be able to access your care, that's challenging for people as well. I don't know if that's particularly just about remote and rural, but that's certainly another issue that we have found in our work that we've done.
Yep.
All right. Oh, sorry about that, Peter.
No. I was just going to say that's it. Yeah.
Fantastic. Okay, so it looks like we've covered all of our questions. Again, speakers, participants, thank you again for today and joining us. Have a great day and be safe out there. Thank you.
Thank you.
Thank you.
Thanks for
Bye-bye.
having us. Bye.